Welcome to a talk on ventilators, and I'm going to have a misnomer for you when we finish the talk. Before we proceed, there are some basic questions. Which one was the first ever ventilator discovered? Do you know the name of it? I think you know. It's called iron lung. What's the principle of functioning of iron lung? Any idea?
It was for polio patients.
That is correct.
The pressure differential.
It's a negative pressure principle. So it mimics how we actually breathe. Put the body in the airtight chamber, keeping the head and neck out, and you apply negative pressure. That's the inspiration. Let go, that's the expiration. Believe it or not, as late as about 3 years ago, there was a patient in Germany on iron lung ventilator, and she had weakness but not complete paralysis. So she will work for a few hours, go in, rest for some time, come back out, and get on doing her thing. This was on the television in the US that I saw. So that's iron lung. From there, we have made significant progress. And before we talk about the newer gadgets that we use, I want to address this three very briefly and then move on. What is HFPPV, HFJV, and HFOV?
Low pressure ventilation.
High frequency positive pressure ventilation, high frequency,
Jet ventilation.
and the last one?
Oscillatory.
Oscillatory ventilation. These are all good for little people, newborns, prematures, very young. Haven't been found to be as useful in adult population for a long term in an ICU setting. Even though I personally have used positive pressure ventilation, but hasn't been shown to be as effective yet. Jet ventilation and oscillatory ventilation, if you rotate through DQ, you'll probably get to see them. One other factor or fact, what is the respiratory rate in all these three? Hundreds per minute in positive pressure ventilation, thousands per minute in jet ventilation, and tens of thousands per minute in oscillatory ventilation. Go figure that. Okay. Basically, ventilates the dead space. And because the dead space is greater in adults, it doesn't work as well. Okay. What is cycling of a ventilator? Cycling of a ventilator, up and down, inspiration, expiration, inspiration, expiration. How does that movement occur? There are three different ways. How does machine change from inspiration to expiration? You know.
You mean like the bellows moving and the valves?
Yeah, how do they move? What are the forces that move them from one to other?
It's pressure from the central
One is pressure, another
flow.
What's the most common way we ventilate patient?
Volume.
Pressure, volume, and third is time. At any given time, there has to be a combination of either pressure and time or volume and time. Because if you don't have, let's say you have volume 700, machine will go and at 650, all of a sudden there's a small leak. It cannot reach 700. Then machine will just stop, basically. So that's why there has to be time when it will cut off and machine will start alarming so to get our attention. So its commonest mode is volume and time, and the pressure is another one. Okay. Now I want you to list all different modes of ventilator, starting from the oldest mode, and then we will talk about each of them. What happened from iron lung? Which one came about? What is it called? Different modes of ventilator.
Pressure control.
Sure, pressure control is somewhere in the bottom, but yes, pressure control ventilation.
Assist control.
Assist control, yes.
Volume control.
Volume control is the most common one, so we won't list, but that's one of them. Yes. What else?
SIMV.
Yes.
PRVC.
Sorry.
Pressure regulated volume.
I would go with APRV. What was the first ever mode from iron lung? Sorry.
Pressure support.
Pressure support is another one that will be added. We'll keep adding. There are some gaps. We'll fill them and then we'll talk about each one. What else do you dial in from the machines? Besides, I'm not talking about rate FIR2 or tidal 1, but everything else.
The inspiratory time.
Sorry?
The inspiratory time.
That will come in another way. It's called IRV. You know what does that stand for? Inverse ratio ventilation. We'll talk about it. But what was there even before assist control?
Manual.
Well, we're talking about ventilator.
Another person.
Sure, we're talking about still a ventilator, a device, a machine.
I love this.
That's a move back, but a little beyond that. When you don't have to use your and my hand, and it can operate even when we are not standing there. CMV was something that came about first.
SIMV.
SIMV is
Oh, yeah.
that happened. But before SIMV, what was it? From CMV, it became IMV. And then IMV led to SIMV. Okay, we have listed all the modes that I want to talk about. There are 3 other things which are supportive things, not necessarily primary. But what would they be?
CPAP.
CPAP,
BiPAP.
BiPAP.
Micronasal cannula.
One last one that we dial in.
PIP.
Yes. Okay, so these are the different modes and ancillary things that we can do with the machine that we're going to talk about. Let's start with CMV and IMV. What do they stand for?
Controlled mandatory ventilation.
Controlled, continuous, mandatory, mechanical, whatever terms you want to use. So that's CMV. What about IMV?
Intermittent.
Mechanical ventilation. What's the difference between the two? Besides that, the word suggests continuous and intermittent. That's important, but
In CMV, the ventilator determines all the inspiratory cycle. Like all the ventilations are controlled by the ventilator. In intermittent, there's a preset amount of ventilations that the machine will give, but the patient can also trigger this.
pretty close. When it came about in the bad old days, patient wasn't breathing. That's when they call it CMV. Then what happened is, patient started breathing. So now what do we call it? Because it's not controlled anymore. There is patient interaction. So that's when they call it IM. That's what I think. There's no other difference. And you don't really need to worry as much because you're not going to really talk about it much, nobody's going to ask you much about it, but I like to talk about historical perspective about why we went to where we went. And that's why it's important to learn CMV and IMV. Now that having learned that, when the IMV happened, when the patient started breathing on the machine, it was uncomfortable. Because machine may be trying to give inspiration, patient is trying to expire. So that did not work well. Patients did not like the mode. So that's when, as necessity is mother of invention, You came up with
SIMV.
S and V. What's the difference now?
Synchronized.
It's synchronized. So what happens is, when patient is breathing, machine will sense that and give a full breath to every initiated breath, up to a point. And what is assist control?
It delivers support with every breath that the machine delivers and the patient initiates. So you're at a risk of hyperventilation.
So let me give you an example. Machine and patient. Machine rate is dialed in as 10. Patient is breathing at 16. And the tidal volume set is 700 cc's. If patient is in SIMV mode versus assist control mode, how many breaths they will get 700 cc tidal volume? What do you think?
Which mode are we in?
I'm asking both modes. So what will happen if machine is in SIMV mode? How many breaths out of 16 patients will get 700 cc of tidal volume?
10 for the SIMV.
In SIMV is going to be, I think, 26 ventilations.
Okay, 10, 16, 6, 26.
10.
10,
16.
16. Okay, what happens in assist control?
Oh,
Assist control, I think, 16.
16.
so the machine's getting 10 and then the patient's breathing an additional 16 or the patient's breathing at 16?
Patient is breathing at 16. You have dialed in 10 from the machine.
Okay,
What will happen? That's the question.
16.
16.
26.
26.
Assist control.
Yeah, assist control right now we're at. Okay. Some right, some wrong. This is what happens.
Shotgunned it.
That's why we are here, right? That's the part to learn. And we all always keep learning. In the mode of assist control, every breath the patient initiates, machine delivers full breath. So the total rate will always be what patient is breathing, except if this rate drops to, let's say, 8, patient's rate drops to 8, but you have a machine giving 10, then it will be 10. Okay? If patient is not breathing at all, then it will be 10 in both SIMV and assist control. The problem is only when they start breathing. When they start breathing in assist control mode, every initiated breath gets full tidal volume of 700. While in SIMV mode, only 10 breaths will get 700 cc of tidal volume. So, other 6 breaths, patient will get whatever they can generate, which could be 50, 200, or could even be a liter. But in assist control, that will not be. All breaths are going to be supported and giving tidal volume of 700 cc. So that's the difference in SIMV and assist control. Clear enough? Okay. So if patient is breathing under 10, then basically there is no difference between SIMV and assist control. They are going to get a total of 10 breaths worth 700 cc of tidal volume. All right. Pressure control ventilation and IRV. What do we mean by pressure control ventilation?
A breath is delivered until a certain pressure is reached, right, for the amount of time specified.
Right. The machine is directed to give specific amount of pressure. The volume will be varied, and that's part of the problem. That under pressure control volume, regulation or a mode, patient is going to get different tidal volumes with every breath, which could be more, which could be less, typically less. So what will that lead to? What are the ramifications?
Hypoventilation.
Hypoventilation is the real problem. Then why do we put patients on pressure control ventilation? What's the indication? See, the normal conventional mode is volume control. When we have volume control, patient, if the lungs are stiff, the machine will require greater amount of pressure to deliver the same tidal volume. And then there is risk of barotrauma and the consequences. So to avoid that, we develop pressure control ventilation, where you dial in pressure, 20, 25, 30, whatever you choose. And patients' peak airway pressures will not cross that limit. However, the tidal volumes will be different. So that's when pressure control ventilation is used. It's not exactly very physiological way of breathing. The easiest way to describe is if I put pillow on your face and ask you to breathe. That's how it feels. So you should sedate such patients and not kind of have them awake and being uncomfortable with the breathing. What is IRV? Remember I said inverse ratio ventilation. What ratio are we inversing?
The IE ratio,
IE ratio, what's the normal ratio?
1 to 2.
1 to 2 is the normal ratio, so do you go and do 2 to 1? Not really. What you do is 1 to 2, 1 to 1.8, 1 to 1.5, 1 to 1, 1 to 0.8. I've gone up to 1 to 0.25, so that's 4 to 1. Significant difference. Of course, the patient unfortunately did not survive, but that's how far you can go. When would you use IRV? What function of lung it's going to help with, and what function it's going to hurt?
Restrictive lung disease.
That's a diagnosis, fair enough. That condition will probably benefit from IRV. But remember the two functions of lungs that we talked about before.
Oxygenation and
Ventilation, right? So IRV is going to help which function? You're prolonging the inspiratory time. That helps what?
oxygenation.
Oxygenation. So by increasing the inspiratory time and attempting to inverse IE ratio, you are helping oxygenation at the cost of?
CO elimination, CO2 elimination.
Right, because your expiratory time is getting shorter. And because of that, there isn't enough elimination of carbon dioxide. So you're going to have hypercapnia in this patient. Just on a side note, how do you treat that hypercapnia? What will you do? Remember, you're maxed out on things.
Increased ventilation.
You're kind of maxed out on the things that you can do from that machine. Just because patient is very sick and requires every bit that you can give from the ventilator for that PO2 or bare minimum. What's the minimum PaO2 that you would want in a critically ill patient? Critically ill patient. Any number? Any guess?
At least 50.
50.
8.
80.
60.
60.
55.
55.
50, 60,
Good.
80.
C1.
60 is actually correct. Why?
It's the minimum.
Association.
Yeah,
Curve
that's
thing.
Oh, the curve.
Which curve?
The oxygen dissociation curve.
Oxyhemoglobin dissociation curve is what we are talking about, and it is an S-shaped curve, and this knee rests with 60 PaO2 and 90% saturation. That's why 60 is the correct number. You go to get to 100%. You will have to have a PaO2 going from 60 all the way to 600. Okay. So that's why you don't push the envelope except at 90%. So you have not been able to oxygenate, that's why you have inversed the IU ratio. Now what happens?
Do something with
How
that
do you
curve.
deal with CO2 that's climbing up?
We're maxed on rate and
Everything is maxed from that machine.
We can try to increase the flow rate. Will that work?
Everything
That's
you've
maxed
done
out.
from the machine. So all other means is what you need to bring in.
What is our PaO2?
Give some bicarb.
PaO2 is 62. Exactly. Bicarb is the answer. And I even put patients on bicarb drip. You can say that it's counterintuitive, right? Because that's going to be broken down into CO2, etc., and more load. Yes, but what you're trying to do at this point is buying time. Buying time for a day, 2 or 3, so that surgery that has occurred, antibiotics that's going, all the other supportive measures work to start reversing the process that patient is under at this point. So that's what you do for IRV, consider even bicarb. What's APRV? Airway pressure release ventilation. Okay, that's a relatively newer one. I have used, and the purpose here is it's basically PEEP and peak airway pressures. They are both regulated, and patients are breathing in. So if you look at the flow pattern, blue, this is how it looks like. This is the lower pressure, this is the higher pressure, and patient is breathing in between. So there's airway pressure, release, ventilation. You determine the lower pressure, you determine the higher pressure, and have the patients breathe in between. The lower pressure is going to be equivalent to PEEP, that will help with something, and that will talk, and then higher pressure will limit peak airway pressure so that the chances of barotrauma are less. Okay, so these are the most commonly used modes. Now we have these 4 things that we want to talk about, which are not primary ventilatory modes. They are adjectives or adjunct modes. And one of them is the misnomer. What does BiPAP mean?
There's an inspiratory and an expiratory pressure.
Right? And if you put it simply, BiPAP is pressure support plus CPAP. Okay? So we will kind of leave it at that. But the good thing about BiPAP, it can be done from a separate device. You do not need a ventilator to do that. Okay? And same thing with CPAP and pressure support also. So you can do it from a separate device. And there is a nasal mask that you put in, and it can give either only inspiratory support or expiratory support or both. Okay. So that's BiPAP. Pressure support. How do you define pressure support? And then I have a short definition.
Inspiratory. I think it's similar to BiPAP. The patient's intubated.
No,
There's an
remember. No. Pressure support can be delivered, so to speak, from BiPAP. But BiPAP consists of both CPAP and pressure support. So it can give support during inspiration as well as expiration. Pressure support, commonly you give it from a ventilator. But what's the definition?
In pressure support, it usually requires a spontaneously breathing patient, and upon inspiration, they're given a set pressure support.
Set pressure.
But there's also an expiratory pressure. I don't understand.
If
Sorry,
you
say that again?
Isn't there also an expiratory pressure that's
pressure support, unless you
not
set
on pressure support?
unless you set
Unless you said a peak.
The book description or definition is amount of pressure given during inspiration.
Okay, I guess I've just never seen it without a PEEP. Never seen pressure support without any like positive pressure while expiring. It's always like 8/5.
Let's finish all this, and then if you still don't understand, we'll talk, because I think you're going all over. And it will all be clear by the time we finish. So pressure support is the amount of pressure given during inspiration. That's the book definition. The Shah version is it's the amount of pressure given towards the end of inspiration. And I'll explain it to you, which you won't find in any book. But remember, when the SIMB was developed, what's the problem with SIMB? Those example of 16 breaths and the machine is set for 10. So 6 times patient is taking his own breath. And the other 10 times, patient initiates a breath which takes only 25 or 50 cc's and the machine delivers full tidal volume. But what if patient can take, instead of that 50, 200, 300 or 500 cc's? Machine is not going to allow that. Machine will allow that only for the breaths that you dialed in over and above 10 breaths, or that patient is breathing over and above the machine. But all other breaths or the machine supported breaths, machine will not allow patient to continue to breathe better and better as time goes on. That was the challenge with SIMB, that's why pressure support was developed. Now if we go by definition, then it's a pressure given during inspiration all the time. So then the tidal volumes again should not be changing, but it sure does change. And I'll explain in a moment. But before that, it's important to know, pressure support is only during spontaneous respiration. Okay? So, you have a patient on SIMB mode and patient is over breathing the vent, those breaths, machine will give pressure support. If you change that to assist control mode, if you notice all of a sudden the pressure support actually will disappear from the screen, because there is no pressure support when patients are being ventilated with assist control mode. Because every breath that patient initiates, machine is going to give full time. Okay, so there is no pressure support with assist control mode. It's there either standalone. You can ventilate a patient just with pressure support, assuming that they are of course breathing. Or it's with SIMB mode only for the breaths which they are taking over and above the machine dialed breath. Now, coming to explanation that I was giving you about, it's a pressure that's given at the end of inspiration. This is how it looks. Pressure support. 0, 5, 15, and right now zero pressure support. This is how it looks. Patient initiates the breath, and then this is the breath that patient is taking, 200 cc's. There's zero pressure support. Now you add 5 of pressure support. So now what happens is, what I believe, the moment they have taken their breath and ready to expire, pressure support kicks in and gives an additional air, additional tidal volume. And this is how it looks. So this is the 200 original, and then this is the additional from the pressure support. Let's say that's 400. Now, 4 hours later, the patient can take 500 cc's of tidal. Remember, in SIMB modes, the machine supported breaths, machine will not allow that to happen. So here now, this is what will happen. Patient will initiate, go, then the pressure support will kick in. So there will be 500 plus the 400 from the pressure support, and now you have, instead of 600, 900 cc's of tidal volume. If the pressure support was continuous, why would that happen? That's my question. Probably there is no answer, but this is important to understand. And if you go and look at the machine, you will actually see this, that the tidal volumes increase over time, while in SIMB modes, that's not going to happen. So that's the pressure support. Okay, CPAP and PEEP. What does CPAP stand for?
Continuous positive airway pressure.
Sorry?
Continuous positive airway pressure.
Right, and what does PEEP stand for?
Positive end expiratory pressure.
Any difference between the two?
One's continuous.
Very good.
At the end of expiration.
Another one is at the end of expiration. Right again. Those are the words that it says, right? But one of them is misnomer. Okay. Let's address CPAP first. Another element between the two, they are same. And yet, CPAP is the term that you use when patients are breathing on their own, spontaneously breathing. While PEEP is the term that you use when they are being mechanically ventilated. Okay. Now, draw it for you. Which function of lung both of them have? Out of those two?
Ventilation.
No.
Oxygenation.
They both help for oxygenation. Pressure support actually increases the tidal volume and thereby minute ventilation, so it helps with ventilation. Okay. This is how it's going to look. We're going to do both on the same graph. Okay, let's go with CPAP first. 0, 5, 10, 15, 0 of CPAP. So this is how it looks. Right? So there is spontaneous breath, there is negative pressure, and it flows up. Now you add 5 of CPAP. So what's going to happen at 5 is going to stop because there is continuous positive airway pressure. Then the next breath is going to be literally same breath, but the baseline is raised. So that's how CPAP looks like. How does PEEP look? This is normal mechanically ventilated breath with 0 P. Now we add 5 P. So at 5, you're saying that there is positive and expiratory pressure. So it should stop, right? And it does. So then, you don't tell me that the pressure will be higher before the next breath or before next inspiration. So ideally, or not ideally, but as per definition, this should come down before the next breath, right? The pressure is positive before inspiration, but it does not happen that way. Simply what happens is, the baseline is fixed. So it's not positive and expiratory pressure. Simple as that. I'm sure he would agree. He has seen enough of the machines that even in the operating room setting, when you dial in 5 or 10 or PEEP or whatever PEEP, this machine, the dial does not come down to 0 before the next breath. It stays to whatever level of PEEP and then goes up from there.
Can you simplify it and say PEEP is CPAP for mechanically ventilated patients?
You can say so. Yeah, absolutely. And I'll go a step further. You can say PEEP is for spontaneously, PEEP is CPAP for spontaneously breathing patients. So that's why I said that they're both same. They both do the same thing. One term is used when they are breathing on their own, and the PEEP is used when they are not, when they are being mechanically ventilated. Now, is all this clear? Because you seem to be a little bit on all sides. Now, I have my theory of why PEEP is called PEEP. And then the nomenclatures or the terms that we coin, unfortunately, have no dollar value. So it doesn't get changed as often. And that gives me an opportunity to keep talking about a misnomer. Right? So, but I have a theory about where does it come from. And for that, you're going to work with me for this graph. Sounds familiar, right? 1, 2, 1 plus 2, 3, 4, 1 plus 4 is 5, 6, 4 plus 6 is not 10, but it is 7, and this is 8, and this is 9. All right, what are these?
Number 1 is tidal volume.
Good. Okay. Number 1 is tidal volume. You got that. Number 2.
Inspiratory reserve volume.
You got that. 1 plus 2 is 3.
That is your inspiratory capacity.
Very good. Number 4.
Expiratory
reserve volume.
ERV. 1 plus 4 is 5. What's that?
VRC. Expiratory capacity.
Very good. Number 6.
Reserve
Functional.
volume.
Reserve.
Not the reserve, but the different term.
Residual.
Residual volume.
volume. Number 7, which is 4 plus 6. So ERV plus residual volume. That's number 3. Sorry?
Functional reserve capacity.
Functional residual
Residual
capacity.
capacity.
FRC.
Mhm.
Number 8 is the whole graph, drone graph.
Vital.
Vital capacity, and number 9 is the whole thing.
Total lung volume.
Total lung capacity. So out of this 1 through 9, which one is most important for oxygenation?
1.
Nope.
2.
Nope.
For oxygenation.
8.
I believe that
Nope.
it is 7.
4.
It is 7.
Why 7?
Look at that. Functional residual capacity. That is what was learned, that number 7, functional residual capacity is most important for oxygenation. Now just imagine, what is functional residual capacity? After a normal expiration that happens, whatever air that's left inside. So the thought was, if we increase that amount of air, there will be more time for oxygenation to occur because the blood continuously flows through the alveoli. And the alveoli collapse, so there is no oxygen. But if we keep them open, then there will be more chance for oxygenation. That's where they applied pressure. That did work. So now, instead of closing it here, maybe they started closing here. So there is more volume left inside. More volume of air inside, and that happened because of positive and expiratory pressure. So that's what they called it. And of course, I'm sure that they realized that it's not only an expiratory, it's just the baseline is raised and you breathe above that. So that's where the term PEEP comes from. That's where nobody really paid attention to change it. But if I was to call it, I will call it PEIP, positive and expiratory and positive expiratory and inspiratory pressure.
I would call it VPAP.
VPAP, okay. What is that?
Ventilatory.
Positive and
Positive.
expiratory pressure, but no, you can't go into positive. You have to add the word inspiratory because the pressure is out there. And that's more for discussion, thought, and where does it come from? So that's where PEEP originated, and that's my theory of why it was called PEEP, and then nobody paid attention until I come and keep talking about it being a misnomer. But it is, because it's not only an expiratory, the pressure is high even before inspiration. Thank you for your attention.